Good afternoon. I wanted to come on camera for a minute to introduce myself. My name is Katherine Crowell, and I am a Senior Policy Advisor from EPA's Indoor Environments Division, where we promote environmental asthma management and healthy indoor environments as critical components of asthma care. I am very pleased to welcome you to the second webinar in our webinar series on solving for the indoor environmental determinants of health, or IEDOH, in asthma. We have a lot in store for you. Over the next 90 minutes, you will learn about evidence from an important natural experiment in Kansas City, Missouri, highlighting weatherization's effects on pediatric asthma. This presentation will be followed by a panel discussion featuring national asthma experts who will talk about what opportunities this natural experiment may present for asthma programs nationwide. Our goal today is to help asthma programs hear the opportunity with weatherization for asthma prevention and to suggest the multiple opportunities in housing to layer indoor environmental interventions for asthma treatment, prevention, and disparities. The information we spotlight today looks at IEDOH solutions in poor quality housing, focused on the housing and not on children with asthma. In it, you will hear that weatherization activities to improve thermal comfort and reduce energy use also reduce environmental asthma triggers in homes, delivering significant benefits for children with asthma. Our hope is that you will leave this webinar with a better understanding of solutions you may adapt and apply within your communities. We had about 796 registrants for this session, and our audience is nationwide. This map shows the states represented in our audience today, with the white states having no participants registered, and with the darker shading representing higher numbers of attendees. As we begin, let's learn a bit more about who's here and what we are seeking to learn today through this poll. We hope to learn how knowledgeable you feel as you come into this discussion about weatherization as a partner in community asthma care. We will repeat this poll at the end today to compare before and after to see if we are meeting our objectives. I want to thank you in advance for participating. Christina, if you could please open the poll. And I'll just mention a few housekeeping items as you participate in the poll and before we begin. I'd like to ask that you use the chat function in the webinar interface to ask questions throughout the presentation. We will monitor the chat throughout the presentation to prepare a question and answer discussion at the end. We are recording today's session to make it available on asthmacommunitynetwork.org, and all participants, other than our speakers, will be muted throughout the session. Christina, could we see the results from the poll, please? Great, thank you very much. It looks like about half are somewhat familiar or very familiar, and about 28% are a little familiar, and 17 are not familiar at all. So this is great to see that at least you all have some familiarity, and we hope that by the end of today's conversation, you will have built your level of comfort and competency in your familiarity with weatherization as partners for indoor environmental interventions for asthma. Next slide, please. At EPA, we build capacity with communities to address the indoor environment as a standard part of asthma care. We focus on reducing asthma disparities because we know that poor and minority children are disproportionately affected by asthma, with worse health outcomes from hard to control asthma. And these same children are often covered by Medicaid, and are more likely to live in substandard housing with more exposures to IEDOH that can drive asthma health outcomes. IED has always tracked asthma disparities and focused our asthma efforts on disparities because that lens brings into focus the critical role of in-home environmental interventions in comprehensive asthma care. In-home environmental asthma interventions are one example of solving for the IEDOH in asthma. Today, we'll hear about another example of an IEDOH solution, partnering with weatherization for structural interventions in homes. Now, what exactly do we mean by IEDOH and why did EPA create this term? I'm just going to spend a couple minutes unpacking the importance of this term. Many of you may likely have heard of the social determinants of health, the SDOH, terminology now common across sectors, particularly in public health, but also widely used in healthcare, housing, environmental, energy, and community development sectors. SDOH are conditions in the environments where people are born, live, work, play, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. This infographic, which is based on a scientific literature review and is aligned with the Department of Health and Human Services Healthy People 2030 initiative and the World Health Organization's definition of the SDOH, shows the SDOH grouped in 5 categories and offers one way to visualize the SDOH and to estimate each category's relative contribution to health. In IED's asthma work, we encounter the SDOH terminology frequently and increasingly, and we recognize our mission at an intersection where disease disparities and poor quality housing co-vary. The term indoor environmental determinants of health helps to contextualize where our work falls into the large spectrum of SDOH, and it underscores the reality that homes and buildings and their corresponding indoor environments where people spend 90% of their time may either reduce or amplify an individual's quality of life and disease outcomes. Zooming in, the IEDOH are a subset of SDOH clustered in physical environments that co-vary with housing quality and access to quality medical care, as we can see here. And Christina, if you could just click one more time. Thank you. The IEDOH are modifiable indoor environmental factors, such as the presence of household air pollution, temperature variations, pests, mold and moisture, chemicals and irritants, among other examples highlighted in the graphic on this slide, that influence risk and experience of disease, including asthma. Evidence shows, for example, that the IEDOH highlighted in the physical environment and SDOH highlighted in medical care on the slide are key drivers of asthma health outcomes. In fact, this close-up of the IEDOH shows multiple drivers of asthma health outcomes and asthma disparities and highlights the critical role of in-home environmental interventions. This view also suggests multiple paths for delivering environmental interventions in homes, ranging from the structural prevention built into housing to access to culturally competent in-home asthma care with tailored environmental counseling. When we focus on the IEDOH, we see that all home-based healthcare and all structural housing offers a chance to address or worsen the IEDOH and to prevent or degrade related health outcomes. Today, we will learn about possibilities for structural prevention with weatherization partners to address some IEDOH and the effects on asthma. We know that delivering in-home environmental interventions for asthma often requires partnerships to gain access to homes and schools, for example. Today, we will explore one type of home visiting partner, weatherization programs that deliver structural environmental interventions for energy efficiency. These programs typically offer more structural work than most asthma home visiting programs take on. Work like air sealing, duct sealing, insulation, and window replacements. In our IEDOH webinars, we typically showcase asthma care models where the clinic initiates partnerships with community health workers, schools, and others to reduce environmental asthma triggers for children with hard to control asthma. Today, we bring your attention to a different opportunity to address the IEDOH in asthma at scale across housing in the results of a natural experiment in Kansas City that begin to suggest the impacts possible for asthma through structural IEDOH interventions like weatherization that can be built into homes. With that, I am honored to introduce our speaker from the University of Missouri, Kansas City, where Dr. Neil Wilson is the Associate Director of the Center for Economic Information. Dr. Wilson's research focuses on the built environment's influence on the production of health outcomes, and his work on the relationship between housing and pediatric health, specifically lead poisoning and asthma, is distinguished by its use of GIS to focus on patient-level health outcomes and address-level housing conditions. His work investigates the social determinants of health, the conceptualization of housing as healthcare, and quantifying interventions into the environmental causes of chronic disease. Dr. Wilson's recent publications describe using a low-cost, non-invasive exterior housing survey as the basis for an exterior housing-based lead risk index. Dr. Wilson is also special faculty at the California Institute of the Arts and the founding director of the Museum of Bottled Water. With that, it is my privilege to turn the presentation over to Dr. Neil Wilson. Welcome.
I'm really, really glad to be talking with everybody today for a couple reasons. Most of the time, my work is about the production of disease. And in this presentation, I'll be talking about some treatments for disease and some really promising results. And so that's really quite a joy to share with people. Right as I get started, I'd like to thank a couple people who aren't on the call, but people who helped in earlier forms of this research. I'm talking about Claude Alamont and Dr. Linwood Taki, both of whom helped quite a bit in the earlier stages of this project. I'd also like to thank the Metropolitan Energy Center. Without their contributions and support, this wouldn't have happened at all. So to start off with a headline summary, so we know where we're going to go. If anybody needs to cut out during the talk, you'll still get the balance of what I'm talking about. Just to talk about the quantifying of these benefits. We find a 39% reduction in acute asthma exacerbation encounters following these energy efficiency enhancements. Energy efficiency enhancements is the technical term. I'm going to call them weatherizations throughout this presentation. And the results are for the pediatric population in Kansas City, and I run a couple different specifications, and that 39% reduction is a conservative estimate among the results that I found. I want to emphasize that weatherization produces tangible health benefits, that there's a growing and existing body of literature, and this just supports that. I'm going to talk quite a bit about the natural experiment and how we generated these results, with a particular emphasis on the fact that we're doing address level analysis of particular individual patient encounters. And at the very end, I want to emphasize that there is opportunity to extend this analysis in meaningful ways, many meaningful ways. Yeah. So I'm presenting an updated version of a report that was published online last year. And the results are slightly different, the counts are different, and the headline finding is slightly more impactful. And there are some reasons for that, and I should say that up front. We specify the age differently in this in this analysis that we did earlier, we're looking today at the results of children 2 to 18 years old. And as you may know, diagnosing asthma among children who are under 2 is difficult and generally not done. There was also some additional data work in terms of building up the data set more completely, and also a different model specification. I'm using a negative binomial model instead of a Poisson regression. If that means something to you, we can talk about that a little bit later. Reviewing I mentioned, right, that there is a literature that supports this, and our findings are largely consistent with the existing literature. 2 things in particular from this slide: this 6-fold reduction in the likelihood of a emergency department visit after the weatherization, and then this large New Zealand cohort study. There's some really great population health longitudinal studies coming out of New Zealand. And so I really recommend you taking a look at this Howden-Chapman article if you haven't taken a look at it already. But our findings are absolutely consistent with the existing medical literature, but just how we do the study, how the study plays out is slightly different. In the introduction, Kathleen talked a little bit about the social determinants of health, and this is a really good schematic coming out of a recent article that kind of gives us a different way of conceptualizing the social determinants of health, specifically with regard to benefits from these weatherization activities. And when I've got this orange arrow over here kind of pointing at this one line, right, reduced asthma, this is the estimate, this is the focus of today's talk, and this is the mechanism that we're analyzing. And I'm putting this slide up right here at the beginning because it's really important to, to focus on the idea that it's one small part of a larger web. And as each part of the web becomes clearer, right, the web becomes stronger, and the arguments that we can make become more robust. To give an idea of where we're going to go from here, from this sort of grounding in the social determinants of health, I'm going to introduce a couple data sets, and then I'm going to talk about the natural experiment itself, and then I'm going to start talking about results. And getting into that discussion, so to give an idea of how all that's, where we're going to go from here. So the energy efficiency enhancement program that we're studying begins with the American Recovery and Reinvestment Act, and that there were 41 programs that were focused on weatherization developed as part of that, as part of the ARA across the country. And the one in Kansas City called EnergyWorks KC is just one of those 41 programs. And the programs themselves were focused on a couple different components, right? And the primary focus was sort of building out the infrastructure for doing this, for doing the weatherizations. And that involves a lot of different things. It requires making sure that there's skilled workers, making sure there's a financial structure involved that's focused on sort of funding weatherization projects, making sure that people know the benefits of them, making sure they know who does the work, and all that sort of stuff. Those were the focus. That was the focus of the ARA grants. And I should emphasize, and this is sort of related to the natural experiment, although they talked about the potential health benefits, those weren't the focuses of the programs. That the focus was very much on weatherization, quite explicitly. The Kansas City project was administered by the Metropolitan Energy Center. I already mentioned the EWKC project, and the MEC administers a second weatherization project called Home Performance with Energy Star. So MEC provided information about a little over 6,000 homes, and those are both Energy Works programs and home performance with Energy Star programs. It was just a whole bundle of information. I have listed here, address, date, costs, etc. That's there were, I think, 65 fields, right? So this is just sort of a light overview of that information. The Energy Works KC project was limited to Kansas City, Missouri, and there was sort of extra outreach provided to try to encourage participation among 6 target neighborhoods. I'll show you some maps here in a second, and there didn't appear just in the visual analysis that's over sampling from those neighborhoods. The Home Performance with Energy Star program is focused on Missouri, just the state of Missouri. And it's much larger, much wider in scope. So 200 miles north to south and about 90 miles east to west. The program's operated through utility company rebates of up to $2,000. And then there's also a subsidy for energy audit, right? So that the work could be tailored to the individual home. And then on top of those $2,500, participants were eligible for a 0 interest loan of up to $15,000. Both programs were open enrollment to register to residential homeowners, clean title, current on their taxes, etc. Other than that, these were open enrollment weatherization programs. Right? Yeah. This gives us an idea of the scope. The map on your left gives us the home performance with Energy Star, and you see that we go all the way up to almost to the Iowa border at the top, and then almost to the Arkansas border at the bottom. We have a limiting factor, which is the location of our health information, and it's located only in Clay and Jackson County. And then there's a further sort of limiting, and that's the limiting of the Energy Works KC program, and that's to Kansas City, Missouri. If you move your attention over here to the map on your right, the dark black line, that's Kansas City, Missouri. And these sort of salmon-colored shapes, those are the locations of the particular neighborhoods. And you can see on visual inspection that there's not a sort of an over-clustering that's going on in those neighborhoods. The second thing, and this is sort of the special sauce that makes everything possible, is the Housing and Health Data Repository. And as I begin, I should actually send some flowers here to Kevin Kennedy and Jay Portnoy, both of whom are at the Children's Mercy Kansas City, for setting up this Housing and Health Repository back in 2013 as part of a lead tech study. Children's Mercy governs the Housing and Health Repository and has some very strict rules about how it can be used, how the data can be accessed, and so forth, which I'll be glad to talk about in the Q&A. The Health Repository contains, well, it goes from the year 2000 potentially to the year 2023. And it contains encounter level data, demographic records, and visit characteristics. The encounter level data is focused around ICD-9 and ICD-10 codes. ICD-9 codes for the years when they were used. ICD-10 is International Classification of Disease. ICD-10 is the current sort of state of the art, and then there's a couple of bridge years in there, so we can do a crosswalk between those things. So we've got the demographic record with birthday, sex, race, ethnicity, visit characteristics that tell us about who paid for the particular operation, as well as the discharge condition. There's a comprehensive collection of data associated with these ICD-9 codes, and that we look at the characteristic regardless of sequence number. So sequence number just means when you go to the doctor, many times there'll be several things wrong, right? And there's a priority coding of those illnesses, and that we're able to grab any of our characteristic illnesses regardless of where they are in the sequence ID, right? So then we are able to gather a more comprehensive collection of observations. The Children's Mercy health outcomes that are in the collection are asthma, injury, that's poisonings, fractures, sprains, punctures, contusions, as well as a couple control variables. So those well child visits, car accidents, and gunshot wounds. And this is all of the records for all of those conditions in the Children's Mercy data for all of the years of the study. So, for instance, for pediatric injury from say 2000 to 2013, there's over 1 million encounters. Right? So it's just a tremendous amount of information. But that's not the limit of it. We also have information from the Kansas City, Missouri Health Department, observations of pediatric blood lead, and then we have specific address level observations of housing conditions and intervention activities. A housing condition survey that I've used extensively with regard to pediatric lead poisoning, as well as lead safe interventions and Children's Mercy Healthy Home inspections, and the related address level and higher geographic information about the Kansas City built environment. Okay, so now we get into describing the natural experiment. So ideally, if we were going to design an experiment, right, we would take that asthmatic population and we would randomly assign some people to have, some kids to have the intervention and some kids not to have the intervention. And of course, that, we can't do that. So what we've done instead, or what we've observed, and I'm going to give Kevin credit for this observation again, because he's the one that sort of said, oh, perhaps we can find this, is overlaying existing intervention studies with comprehensive surveillance. And in that case, we can see the kids that are matched to the intervention versus the background population, right? So the schematic on the left-hand side of your screen talks through this this randomization process, right? So we've got a limiting of the weatherization addresses to the area in which the asthma is observed, right? And we've got a limiting of the asthma population to that pediatric population I talked about before, 2 years to 18 years. And then once we have that, we do a simple address match, right? Are these kids in those locations, right? But we don't discard the unmatched addresses. We use those as sort of the background observations, sort of a first control population, so that there's an initial randomization. And recall what I said before, that that these projects were not sold as health interventions. Right? They were sold for the purpose, or publicized for the purpose of improving the condition of the home, right? And so that's our first randomization. And there's a second randomization, which is a before and after weatherization activities, right? Because you don't, not all the weatherization happens at the same time. It ends up being sort of staggered throughout the period. And so that creates a second randomization. So then we have a before and an after randomization process. You may say, well, you go from sort of 5,000 observations in the study area to 200 observations, and doesn't that seem small? And just as a back of the envelope calculation, right? In 2012, it was about 43% of homes had kids in them. And then among kids with asthma, you have about a 10% asthma rate. So that gets us down to just about 214. The back of the envelope calculation I had was 217. So this is a sample number consistent with that simple modeling. The thing about the natural experiment is it allows us to make causal claims, stronger causal claims than can normally be made with observational statistical analysis. The other thing to keep in mind as I talk through the results of the study is that there's a couple different groups and there's a couple different sample populations. There's the home address, right? And so that's either an MEC home, right? So a home that received weatherization, or a home address of a child with asthma. And then you have the children with asthma, and then you have pediatric asthma health encounters, right? So those are all sort of three different things. And I report observations for all of those different things as we go along. And then there's a couple different study sample populations, right? So you've got the before weatherization children, you've got the after weatherization children, you have the control population, and then you have a small group of kids who are at that, who are at the MEC addresses, and we have direct observations of their asthma encounters before and after. And I'll return to each of these populations as we kind of go along. As we talk about just the patient sort of information, we're largely consistent between the all asthma encounters data and the pediatric asthma encounters in the study sample. The race and ethnicity category that I've consolidated into one, it was done to try to get a Latinx variable that is consistent. The race, or that the Latinx ethnicity, was separated between two categories, and so I had to combine those into one to make a sort of a consistent thing. And so what I'm presenting here is a bit of a fudge, but it's the best that we can do with the data as presented. The other thing is medical coverage. This is consolidated again from any sort of state level medical coverage, any type of commercial medical coverage. That all gets consolidated into these three smaller fields. One thing to notice, and this is actually the biggest discrepancy between the asthma population and the pediatric and the study sample, right, is that there's more commercial medical coverage in the study sample than there is in the background population. And I think that's because people who own homes are more likely to have commercial coverage. I can't be positive. I'd be curious to hear what you all think about that. Looking at the distinctions between the housing, we can see how much was spent on the individual homes, and it's up. It's about $1,500 at the median, a little over 2,000 at the mean, and then we've got an idea of the percent change in airflow improvement, and it's 22-24% there. And if we look just in the wide range of observations, it actually is quite broad, almost $20,000, well, a little more than $20,000 in the children at weatherized addresses, $60,000 range among the all asthma characteristics. We include homes from inside Kansas City and outside of Kansas City, homes that were built before 1980 and homes that were built after 1980, in a way to try to control for the variation that we might see on the basis of those conditions, right? Sometimes there's a thought, well, weatherization works, but only for people, in the city and so forth. And try to control for that variation is an important aspect of doing the analysis in a robust way. Looking pretty quickly at the actual interventions that we're doing, about 80% of the interventions in the MEC homes were air sealing, insulation, or both. But there is a wide variety of interventions that took place. I should say that what I have presented here, although it seems like a long list, is actually consolidated from a much longer list. I've made single door and plural doors, as well as windows, into a single category. It's unclear from the level of analysis or from the data that was provided, the distinctions between those characteristics. And then there's also an ordering operation. For instance, air sealing, insulation, duct sealing. Is that the same as insulation, air sealing, duct sealing? The same three characteristics, but in a different order. I made the assumption that they are for this particular listing. Anyway, it's important to disclose that sort of thing. Yeah. Okay, so finally we can look at the effects, right? And so these are just counts, and this slide is a bit of a mess, but stick with me and I'll explain. If we look at the table at the top, we're just looking at the percentage of the level 1 and level 2 encounters. The level 2 encounters, that's acute asthma exacerbation, and that the sort of the charts at the bottom let us see how those levels are actually created, right? So the encounter gets coded either as level 1 or level 2 on the basis of severity level from the ICD-9 code, or severity level from patient class, right? ICD-9 code is the doctor's observation, and patient class is where the observation took place. And then we'll code either into the low level or the high level on the basis of the highest results from either of those categories. All right. So now we can compare the all asthma encounters. So according to this, 54% of all asthma encounters were the acute asthma encounter level 2. And if we look at the after weatherization, it was 6% less. It was 48%, right? And that's a significant decrease and cause for reflection on its own. However, these numbers do not take into account time at risk, and it doesn't take into account any of the other confounding variables that I discussed earlier on. So to talk about time at risk, right, because it's not just whether or not, it's not just how many asthma encounters you have, it's the period of time in which those encounters took place. So we develop a time at risk that is distinct for the all asthma encounters, before weatherization encounters, and then the after weatherization encounters. So for the all asthma encounters, time at risk is from your first encounter during the study period to the end of the study period. For the before weatherization encounters, it's from your first encounter until the inspection, confirming the completion of the weatherization work. And for the after weatherization encounters, it's from that inspection until the end of the study period, right? So that's what we're comparing. That's what we're looking at right there, those three things. Okay, so we've got all our data collected, and then I just run a lot of regressions, right? And I use the negative binomial regression model because that's the standard model to look at over dispersed count data. And what I end up reporting are two things. I report incident rate ratios and confidence intervals. An incident rate ratio, the easy way to interpret it is just think of a value under 1 indicates that there's a decrease in the acute asthma exacerbation encounters and the rate of those, right? And the confidence interval sort of tells us the bounds of statistical similarity between the IRR, right? And if the confidence interval, that 95% confidence interval that I report, contains the number 1, then that sort of tells us that there's no statistical difference between the reported value and there being no statistical difference, right? So we're looking for numbers under 1. This is the quick and dirty way of thinking about it. We're looking for numbers under 1, and then we're looking for confidence intervals that don't contain that integer. Yeah. Okay, so then I say I've run a lot of regressions, right? And so right down here, these are our four study sample populations I talked about earlier on. I'm only going to sort of talk about the MECN control population, right? And then, but we can talk about these other ones if you'd like, maybe in the Q&A time. And one of the real distinctions is the size of the population used in the analysis, right? And so we want to use as many observations as we can. We don't want to lose any data. So this is really the best one. Yeah. Okay. And so I run a lot of models. So at the top here, model 1 through model 6, each model adds a different or adds an additional confounding variable, right? In Kansas City, the age of the home, payment type, race and ethnicity, and then finally sex. And that down here at the bottom, I report just the weatherization variable for all 6 of those models. And then this right here, 61 or 0.61, which represents a 59% decrease in that incident rate ratio, right? So 39% decrease in the observations of acute asthma exacerbation associated with that, just with that weatherization activity. So looking at these models, from model 1 to model 6, we see a resounding consistency. It does change a little bit as we add in those confounding variables. The other statistically significant variable that we look at is this commercial insurance and self-pay. Right? And so commercial insurance is lower and self-pay is a little higher. And this may be because the self-pay variable or people who self-pay may be more likely to use the emergency department as primary care, and that automatically gets coded as a elevated encounter. Yeah. I should say there are issues with every analysis, and I would be a bad social scientist if I didn't sort of bring them up. But we don't have a complete record of all asthma events. We only have a record of the encounters that involve the hospital. Right? I mentioned before the issue about the emergency department. There's other plausible ways to specify tie net risk, and that each one would sort of change the numbers perhaps slightly. There's unaccounted for heterogeneity, not just among patients, but also among the homes themselves. And then there's variation among the interventions that take place. Right? So all of these, we can expect them to change and move the statistical results slightly. And then the final thing is that the precise mechanism that leads to the health improvements is ambiguous. That we've got 4 hypothesized mechanisms that are actually that the weatherization activity is impacting, but we're not quite sure which one has, or which ones, a combination of them, is creating the improvements that we see, right? So it could be that weatherization is reducing moisture, right? It could be that weatherization leads to more money in the pocket of homeowners, and that lets them spend more on their care. Those being actual, just 2 of the several. So we can think of this operation as a hypothesis generating exercise, not just the reporting of the natural experiment results. I mentioned that there are future extensions of the research, and they're actually really sort of exciting. We can dig deeper into the information that we have. We have paper records for each of the homes that received an intervention, and that may contain information about the type of furnace, may contain information about the fuel type of the stove, could involve characteristics of the home. I don't present any evidence about the dollar cost savings. However, in with the Children's Mercy records is a accounting of how much money is spent on different procedures. So if we can estimate a change in the number of procedures and we have an actual cost, then we can get a precise dollar amount for the savings. Right? And the list is quite long. I want to emphasize these last three extensions. The first one is that the ARA programs that I mentioned at the beginning, there's a possibility that those ARA programs could be investigated in a similar manner using data collected by the Children's Health Association. That data is out there, and what it requires is some enterprising scholar to go and dig it up and try to run those numbers. Everything that I talk about today are single family homes. Let's look at weatherization in multifamily homes. I would be really curious to see if the numbers are consistent and so forth. And the final thing is that the Inflation Reduction Act will bring additional weatherization activity. And we should have established surveillance. It's something similar to what we have at the Children's Mercy Kansas City to look at the improvements from that weatherization activity in terms of pediatric health. This is just it's more of a literature review of literature reviews. I'll leave this slide up here for a second. If you want to take a screen grab or something, it also includes down here at the bottom our publication from last year, where you can read in greater depth in what we did. And with that, thank you very much for listening, and I really am looking forward to the discussion and the comments and everything to come. So, yeah, thanks a lot.
Thank you, Dr. Wilson. Your presentation spotlights opportunities to bring indoor environmental determinants of health services to the homes of people who need them with weatherization partners. I'll now ask our facilitator, Kate Hastings, and our panel to join us. Kate is a contractor for EPA, and today's panel includes Dr. Wilson, Kate, and I, and we are joined by Ann Kelsey Lamb and Kevin Kennedy. Ann Kelsey Lamb is the director of the Regional Asthma Management and Prevention Program, a project of the Public Health Institute. Since 2002, Ann has led RAMP asthma efforts that emphasize prevention and management of asthma by building asthma program capacity, linking programs and networks, and mobilizing networks to address the causes of asthma disparities through housing quality, affordability and tenant protections, policies to reduce air pollution and burden communities, increasing access to prevention and healthcare, and asthma workforce development. Also joining our panel is Kevin Kennedy, a co-author of the study that Dr. Wilson shared with us today, and owner and instructor of Healthy Indoor Trainings and Consultings. Kevin is a national expert in environmental health science, safe and healthy housing with over 30 years of experience, and he is a former director of the Environmental Health Program at Children's Mercy Kansas City. Kevin's research focuses on indoor environmental health and home interventions, assessment and geospatial analysis of health disparities and determinants of health and he provides professional training, workshops, and presentations on environmental health in buildings with a focus on healthy housing. As we get started, Kate, do you have any questions from the audience for us?
I sure do. Let me say that the audience chat has been very active. Some of the very first questions pouring in were, how do I get my hands on this recording? How do I get my hands on these graphics? How do I learn more? So I think there are a lot of questions. I will triage those questions for our panel and our time, and I'll start by sending a couple specific questions to Dr. Wilson about the control population. Neil, there was just a little curiosity about, can you describe the control population? Were they co-located with the population analyzed? And they were. And just, can you talk about that control population just a little bit? And also, can you repeat for us, what was the time frame between pre and post weatherization? Yeah, we'll start with that question, just about the control population and the time period of pre and post, and then I'll give you a couple more.
Sure. So the control population was all children in those two counties, Clay and County, who were not matched to an address that received weatherization. And so I think there was about 13,000 kids a year. So there is an open question. I think the second question was, and I say control pediatric population 2 to 18, right? So there's an open question about whether or not I didn't mean to do that. Thumbs up. That there's a question about mapping particular location and mapping particular age associated with the kids, and that would be a entirely plausible thing to do, a nice further extension of the data. Yeah, for sure.
Thank you. And a sort of similar question was, does this analysis account for children who might have moved after weatherization? And that's an interesting and tricky question. Maybe you can help us all understand that question in light of a natural experiment.
Yeah, for sure. So you have to make some limiting assumptions. And so I just looked at the children at addresses, at the same addresses that were weatherized. If a child moved from that location, they fall out of the after weatherization sample. Similarly, that if a child moves into that location, moved into a location that received weatherization afterwards, but didn't live in that same location before the weatherization happened, they still end up in the after weatherization sample, right? So it's, where did you live at the time of the encounter, and that the encounter level analysis. Is that clearer? I hope so.
Yes, thank you. And I'm now going to ask some questions that I kind of want to open up to the group of us on this phone or on this webinar, because they're questions that, first of all, Dr. Wilson's analysis was not asked to answer. And they're, more importantly, I think they're questions that we're all very passionate about. And so the first of these is going to be familiar, especially to this group of people I'm looking at. And it's, how do we think about extending this analysis to renters? And within this question about renters, I think it touches on Dr. Wilson's point about multifamily. There's an even more inside this question, which is, who's eligible for weatherization? So when we think about weatherization as a partner right now, and we're encouraging asthma programs to think about weatherization as partners, we do have to consider who's able to get weatherization, who is weatherization for, and what are the rules governing which houses can be visited. So two-part question there. And I just open it up for all of you to think about, because we're all so eager to see these kinds of interventions extended to renters and other populations who we have good reason to believe are at risk. So let me turn first maybe to Anne, if I can. Anne, only because I know you've thought a great deal about this topic.
Yes, well, first, thank you for the opportunity to be here today and to be part of this discussion. I was very happy to hear that your future research plans to look at multifamily housing, because I think the reality is that many of the individuals and families experiencing asthma are renters in multifamily housing. And I think that that brings up some unique issues. One is that it is harder for renters to control their environment. So we know that when asthma educators go into the homes of people affected by asthma as part of a home visiting program, they will educate them about those things in the environments that are within their control through behavior changes, things like cleaning products or environmental tobacco smoke. But that often they identify structural issues that are really out of the hands of the renters, mold problems, pest infestations. And so it's really important to think about how we can hold landlords accountable and help renters live in healthy and safe spaces. I think one important consideration, I did see a question in the chat around renters receiving services like weatherization, is how we can make sure that they're protected from displacement. So anytime a housing unit is improved, there's a risk that the landlord will want to charge more money for it. And so I think it's really important that any of these programs that provide structural improvements as a service to the renters based on their low income status also have tenant protections built in. And I'll pause there because I know Kevin can share a lot more about the weatherization programs generally.
Yeah, Kevin, if I could ask you to add your thoughts to what Anne said, and also we have a request in the chat. Could somebody give the most generic description of what weatherization is? So I might ask you to do that, Kevin, if you feel comfortable. And I know, there is no generic weatherization, but are you able to speak to that a little bit, Kevin, and just about weatherization access a little more generally?
Those are all, well, first of all, thank you for inviting us to present on this topic. We're very excited to be here. Neil and I are both pretty excited about how this report went, and I have to take a quick moment to say thank you to the Metropolitan Energy Center. Without them and the City of Kansas City, and of course Children's Mercy, and everyone's support for this work, it wouldn't have happened. So very important shout out there. That is a big problem. Both those of us who've worked with healthy home programs, done housing interventions, the property owner typically has to give approval to those. When it comes to weatherization, usually the path of least resistance is single family owner occupied homes. Sometimes it's renter where it's owner occupied homes, or it's rental occupied single family homes, so, but ultimately the landlord has to approve, or the property owner has to approve or agree to whatever the activity is. With multifamily, again, it's the property owner, so it's a lot more complicated. And from my experience of working with weatherization programs, when it comes to multifamily weatherization, there's a real focus on basic things that we heard here, the air sealing and insulation, but really a focus on mechanical system upgrades, because at least in my experience, many of those multifamily that are for low income tenants, they're older housing, or housing that has not seen updates in a long time. And one of the primary focuses is on those system upgrades that are really not doing an effective job of providing the warming and cooling of the home in an energy efficient way, and the systems are in such poor condition they may even be contributing to a poor environment. So there are some complexities in how to identify enough multifamily that has participated in having energy efficiency upgrades done. But maybe this represents an opportunity also, because there is certainly a specific initiative through a lot of the new funding coming through Inflation Reduction Act, over a couple $100 million going to housing, with a focus on some of those multifamily upgrades. So this also represents an opportunity to do some of these longitudinal studies as this funding is implemented around the country. Neil pointed to those 42 are programs. You could go back and look. There are children's hospitals in many of those locales where you could look at the data. There are some important relationships that could be put in place to really try to understand this impact. And in Kansas City, as far as a rental property, it is not all in large multifamily units. We have a lot of single family homes or duplexes or smaller rental units. We're not dealing with large scale units, so that certainly helps us to some degree.
Right, and there are some interesting questions and discussions in the chat about, what's going to be required for weatherization under the Inflation Reduction Act. And for our audience, that's a complicated question that's got lots of levels of who's going to decide what's required. But there's really interesting conversation in our chat about, like, what about air monitoring? Are we doing particle counts before and after, between indoor air and outdoor air? These are all really interesting ideas, and it leads me to ask something I was going to ask you all anyway, which was, if you could design the follow-on study, what exactly would you hope to look for? So let's say you all get to design the exact Inflation Reduction Act study to follow on to this one. What would you look for specifically? What would you want to know? Neil gave us some great ideas, and Neil answered some of the chat questions where folks were asking, what do we think is driving the asthma improvement? Neil was careful to say, we don't know. This is a natural experiment. We know what happened. We can see before and we can see after. And it's kind of a black box a little bit in between exactly what was happening in different kinds of houses. But if you were going to do that next study, what hypotheses would you be most eager to follow on? And I'm going to ask each of you. I'm going to start with Dr. Wilson, then I'll go to Kevin, and then Anne, and then Katrin. If you want to think about a study you might want to design, you can pop in on that as well. But first, let's go to Neil.
Yeah, one of the things, I'll talk about the amount of money that's being spent on each individual home, just because I'm the economist here, right? And that one of the things that I didn't quite emphasize in my slides is that the average amount being spent on those homes was not a ferocious amount of money, right? And so that there's a real question about bang for your buck. The study suggests that as little as $2,000 could have a significant impact. And so I would like to see a really well-funded study that was just looking at those. Is there a quick and simple improvement where we could really look to see if the intensity of the weatherization activity made that sort of difference, with the idea that I'll just.
Thanks, Neil. Kevin, you want to jump on that one? And then
well, you asked, yeah, and you also asked earlier about what is weatherization. So just to be very basic about what that is, typically a weatherization program, once you qualify, they're doing a basic walkthrough of a house to look for health and safety concerns to make sure the house can be weatherized safely. Once they do that, some programs will do what's called an energy audit, where they come in and use something called a blower door. They depressurize the house. These details are available online. Depressurize the house, understand the leakage points around the house. If you depressurize, you can see air leaking in, and you can see where those leakage points are. That helps guide your air sealing. Air sealing is physically closing all those gaps up as much as possible, and then checking what the quality is of the insulation, weather stripping, etc., and maybe increasing that. One of the challenges, though, is when you air seal, you don't want to seal it up so tight, because if you have any kind of combustion appliances or any kind of exhaust fans, those have to function properly. So it's important to make sure you allow for a certain amount of air leakage. You're trying to reduce it down to the acceptable level to improve your energy efficiency, but also make sure the house functions properly as a system. So that's the basic process, ultimately, you hope, leading to big savings in your utility bills. As far as I'm concerned, there's some really interesting questions to know about the individual components of air sealing and insulation. We don't know, for example, for these houses that turned out to be the ones that were the kids with asthma lived in, how much of the house was air sealed? How much of the house was insulated? Was it just a portion of the house, or was it the whole house? That would certainly be important to know. And Neil hinted at the other. What kind of mechanical systems support that house? What kind of furnace? What kind of fuel type? What kind of stove? Is there an exhaust ventilation vent? And then Anne pointed at some of the other things you might want to know, the habits of the families in these homes, if you had any kind of basic survey, because as you weatherize and in theory tighten up the house, are they more exposed to indoor conditions, or have you done something to block out outside air pollution and traffic and other stuff from the outside? We know there's a high infiltration rate of particles from outside to the inside, so maybe that is what's happening. So there's some things there that you could tease. Some people you said in the chat mentioned things you might want to measure. There's a variety of things that you could potentially measure, but they all would certainly have costs associated with them. And I don't think you'd have to look at thousands of homes to figure this out if they are recruited to participate. The beauty of this study is that we were able to do an actual experiment, but it required having access to thousands of records in order to figure out which ones or are there enough that we can join together to do this analysis. So it really helped to be able to do that. And there are lots of other questions that I could get into related to this, but I'll stop there.
Anne, let me go to you, and then I'm gonna take it back and tie it to something in the chat.
Sure, these are all great ideas. I'd be excited to learn about. I think that, first I would say that the take-home message of this webinar, in my opinion, for asthma programs, is that it's really worth exploring partnerships with weatherization programs as well as other healthy housing services. And so when I think about research, I think about exploring those partnerships between asthma home visiting programs and weatherization programs. So we know that there's already very robust evidence demonstrating that asthma home visiting programs improve asthma outcomes, reduce healthcare costs, reduce disparities. And there's growing a body of evidence that weatherization programs also improve asthma outcomes. So I think it'd be important to further our understanding of what the impact of a comprehensive approach would look like, where you provide both services. So in terms of a study design, I think it'd be interesting if some portion of patients who received weatherization services also received asthma home visiting services. And I'd strongly predict that the patients who received both interventions would see greater improvements in asthma outcomes than those who had received just the one. And so assuming this were the case and my hypothesis were true, I think that could point to the need for more partnerships between asthma home visiting programs and weatherization services, and could motivate funders and providers to work toward overcoming some of those inherent challenges of partnering. So things like siloed funding sources, different eligibility criteria and application processes, the whole process of working with landlord for two different programs and interventions. And so if we could streamline some of these challenges based on the proof that providing both interventions will really improve asthma, then I think that provides some real opportunities in practice and policy change.
And Kate, as EPA, I just want to echo my desire for a study similar to what Anne just laid out. I think, certainly at EPA, we spend a lot of time thinking about what is the infrastructure necessary to support community level systems that can ensure sustained access to in-home interventions for kids who need it most. In an ideal world, those interventions would include more intensive remediations. So one of the things I think a lot about is, what does it take at the federal level to help break down some of those silos as it relates to eligibility requirements and funding? And I think, with that information, there's a lot our federal partners could do to help improve communities' ability to partner in this way.
Well, you
So
both
I'll
know
give
you're
you-
speaking my language, and that's why I'm nodding away. I'm also looking at a comment in the chat that I think connects our question about what research do we wish we could do next, how do we get enough data so that we can make the deals? You've all heard me say 100 times, we don't need the data to trace every child through every intervention. We need enough data so that we can make deals at the level that policy gets made and money gets, directed to work. And a question that came in from the audience is that oftentimes programs have to cost justify the measures they're going to deliver, right? And what is it that it would take in order for us to cost justify the measures that Neil showed us were like $1,400 to $2,600 per home, right? I think that was the range associated with 40% population asthma improvement. And Neil even said it. He said, we could go back and get the cost data. We could get that cost data. And there's a question, what kind of research would we need to do a savings to investment ratio that included the healthcare cost savings? You all know I know what I want to hear as an answer, but let me put that out there to you. Those of you who've looked a little bit at some of the healthcare costs associated with, say, asthma hospitalization or asthma ED visits, you can do a little quick math. What would 40% reduction year over year mean at the population level? But the question is how do we demonstrate, how do we do a research now to demonstrate these deals can get made? And I'm just interested in hearing you all talk about if you were to do the healthcare cost savings connection with this, how would you expand that work? And then I'm going to hold in my hopper one more question I have from the chat. How would you think about, Neil, let me start with you, because you've obviously already thought about going back and getting some of that cost data from the hospital to match up with your intervention data.
Yeah, and you mentioned this idea of a 40% reduction, and that just using those numbers, you could do a back of the envelope calculation, and you're saving hundreds of dollars a year, and so within a decade, less than a decade, for a family with asthma, you're paying for the cost of the intervention, and that's a weatherization activity that has a totally different justification for its cost, right? So one of the things that on my sort of headline slide there was that we must include the costs of or the benefits from those weatherizations. Another round of funding, similar to what I had to initially run this study, I hope would allow me to extend the cost analysis, and then it's really a question of convincing other children's hospitals to try to set up a similar surveillance repository, right? To go and actually be able to estimate those costs based on actual costs, right? As opposed to the estimated numbers that are out there already.
I just want to say the chat is blowing up. If I'm missing your question, it's because they're flying in, and I'm doing my best to weave them into our conversation here. Folks, a really neat question came in early in the chat, and it was related to, we don't diagnose asthma before 2 years old, but there is tons of evidence, including evidence of RSV exposure being a precursor to the development of asthma 0 to 2. And we have pretty good information and science indicating RSV incidence is higher among disproportionately exposed populations. I mean, environmentally disproportionately exposed populations. So there are some interesting questions in the chat about how could we think about other populations that might have been affected by weatherization who don't show up in the asthma data. For example, are there, could we think about children under 2 and whether we saw changes in RSV in these, incidents in these same homes? Could we think about others in the home besides the asthmatic child? There's a whole string from somebody in One Health who's not only talking about other people in the home, but companion animals as well. This is obviously a veterinary perspective, one that I've never thought of before, but it's been really intriguing to read the chat. So let's first talk about that RSV 0 to 2. What can we think about with environmental exposures and weatherization? And this is an open one. And I'm going to start with you because I've talked to you about this before. So I know you've thought of it.
Yeah, I mean, it's a really important age. Young children's lungs are developing, and what we know, when I started this work 20 years ago, when we talked about asthma triggers, it was things like how do dust mites lead to an asthma exacerbation. But the scientific evidence that some of these environmental factors actually lead to the onset of asthma in otherwise healthy people has grown enormously in my time doing this work. And I think that preventing exposure to air pollution, both indoor and outdoor, from a very young age, even from pregnancy, will do a lot around asthma prevention. So I think it's a very, very important age to be considering. How that could be analyzed, in this type of study is maybe another question, but very important population to be reaching.
Kevin, can I pass it to you and then Neil?
Yeah, and back to the previous question you asked us about cost analysis. Two components about that. The classic way of evaluating it is ROI calculations, return on investment, and it wouldn't be a heavy lift to calculate an ROI for this, which you look at the healthcare costs prior to a particular date, in this case a weatherization activity, look at the utilization post that date, those are your healthcare costs, subtract the after from the before to get a total savings in healthcare costs, divide that by the costs of program interventions, et cetera, and you get a rough ROI for doing that. And I would absolutely recommend doing that kind of analysis. But the other thing that you pointed to when you're talking about RSV and younger populations is you aren't just looking at the asthma patient. You should be looking at everybody who lives in that house, because everybody who lives in that house is going to benefit. And some of the other work by Oak Ridge National Lab and Tone and his co-authors have shown you got to look at, and they did survey other people in the house, do broader recall surveys. So if you include all of them, I would guess that ROI is going to be really robust. When you're thinking about RSV and other, remember what we learned from COVID about SARS-CoV-2 and its distribution, about viral aerosols. There's a new focus here in the last 2 or 3 years on indoor air quality and the importance of managing viral aerosols. Well, weatherization activities that air seal, insulate the house, and ideally you include the duct system, the air distribution system in that, you have better control in managing the airflow and circulation through the house and making sure enough of it is running through a high efficiency filtration system, meaning you're improving the management of indoor aerosols. And I would expect that you would see, if you really did do that, a reduction in the incidence and prevalence of RSV to some degree, but that would just be one of those factors related to the ROI for health benefit for the whole family.
Neil, did you have anything you wanted to add to this?
The only thing that I would say is that with the we're looking at we're looking at a program that completed in that was concluded in January of 2014, which is over 10 years ago. So we could just use those homes as a sample population to see whether or not we had what's the rate of RSV in those homes. Again, kind of black boxing what's going on inside the home, but looking at that, whether or not the weatherization is a works as a preventative so that's the thing that sort of pops in my head.
Right. And for me, because I think about this all the time, I think, could we look at COPD exacerbations pre and post in these same weatherized homes? Could we look at cardiovascular disease exacerbation? Could we look at ischemic, risk? Because all of these same health endpoints are implicated by indoor environmental exposures. We know the weatherization is doing something to help control, whether it's thermal comfort, as you say, whether it's reducing outdoor particles. Another, so I would love to look at other chronic disease endpoints like asthma that are both respiratory and pulmonary, that we have very strong evidence that environmental contaminants are triggering exacerbation. I think that's how you'd get to this, this cost efficacy would pile up quickly. I'm also really interested in, I don't know that you all can answer this, but I'm curious about the endurance of the intervention effect. And by that, I mean, we looked 1 year after weatherization, but how long does it take for sort of behavioral triggers to pile up and affect the indoor environment? How well maintained are these interventions? Do you guys have any thoughts on that question?
complicated. Well, I would expect that the weatherization would improve. I mean, fundamentally, the primary things that you're being exposed to are particles and chemicals. And if you're doing the weatherization following the idea that I said there, full air sealing, air duct sealing, proper insulation, you've really got better control of airflow. If at least there's been some in-home education about basic cleaning, the overall burden of dust and particles should go down and stay down because, to a degree, because of the long-term efficiency of that system and having upgraded that system. So I would expect that you would see a long-term benefit beyond, the typical asthma studies. At least in my experience, you lose connection with many of the subjects after about 12 months. Their lives move on, other things move on, the kids grow older, etc. But the benefits from weatherization, and I have not seen the data to say how long, but I would think they would be significant and last, way beyond 5 years or 10 years, depending on the individual house and what the weatherization activity is. Maybe longer.
That's very exciting to hear you say that, especially as we think about weatherization being a program for low-income people who we expect may be disproportionately exposed. The idea that though one family may pass through a home, if it's been weatherized, the next family in that home is going to still get the benefit. That's that's great to hear you say that as somebody who I know has great expertise in this. There's a bunch of audience questions on air filtration and how can we think about using filters and portables in addition to some of these structural interventions. Any of you have thoughts on that question or want to say anything about that? I'd love to make time for that.
I'll bet Ann and I are both big advocates for both. Good quality vacuums, absolutely. Portable room air filtration units, and I emphasize the filtration, no ionics, no electronics, no gimmicks, real simple units. There's research to show those things absolutely are very effective, but there's strategies to go along with that. We don't have time to go into the details, but absolutely those are effective. And remember, you can build your own with a box fan and 4 furnace filters. The Corsi Rosenberg Cube has been shown to be very effective for families to make themselves.
And yeah, Kevin was right. Big fan of the portable air cleaners. We've really seen a growing need for them in California with wildfire smoke over the past many years, and are doing everything we can to get them into the homes of all low-income people with asthma. And Kevin is right that not all air cleaners are equally safe, and we really encourage families and programs who provide air cleaners to families to focus just on mechanical HEPA filtration and not the electronic options as the safest choice for people with respiratory conditions. And I think this might be a good opportunity to just bring up one other thought that has been bubbling, and that is just the connection of all of this work to climate change. I think that weatherization is an important tool for dealing with the impacts of climate change. So sealing the home is going to reduce the infiltration of wildfire smoke. Someone thoughtfully pointed out in the chat, it's also really important for protecting people from the dangers of extreme heat. Also think, to the extent that weatherization programs are reducing greenhouse gases, that it is both an immediate way to reduce the impacts and it's a mitigation activity, thinking long term. So it's all really important work.
Yeah, you've heard me say many times, I think indoor environmental interventions are the multi-solving solution for so many of our problems. And if we can get our denominator on returns right, we're going to show that. And with that, I'll say there's a question in the chat that it's, should our nation have a cabinet level department of indoor air quality? And I'd say indoor environmental determinants of health, yes, we should. And I would love to throw my hat in the ring for the job. Now,
and you'd be good at
it. Back with all of you now. Let's think a bit, let's try to bring this back down for what we have now. I mean, this natural experiment is so exciting. It's so compelling. The data that this group was able to bring together to run this work is terrifically exciting. And you hear all of us talking about how much more we'd like to ask this data and similar data because we really believe in these solutions. But let's take it back out a little bit as we start to close and think about what can any asthma program take from this conversation we've had today. Let's think about any asthma program. Let's think about a small rural asthma program that may not even know if they have a weatherization partner nearby. What are the takeaways that you all want to make sure any asthma program would hear from this today? And anyone who'd like to can start there, because I know you'll all have great ideas.
Well, I will say that every county in America is served by community service block grant funding, which typically is your low income heating and cooling support, utility support, some other educational stuff, as well as community action agencies that are often the providers of weatherization activities. So you should be able to serve both urban and rural. We should also put out the caution that weatherization is not all healthy home interventions. It is just one thing that has a narrow set of interventions that complement other interventions. So it should be a tool in the toolbox. And you should be, I've always encouraged over my years of doing this work that you partner with as many community partnerships and organizations as you can and learn to collaborate, integrate, and actually introduce them to each other so that you form a web of support, a safety net that includes all of these opportunities. And then for each family that you're working with, you can tailor what those needs are to try to maximize the support for each family.
Anne, would you like to suggest
Sure,
any-
yeah. I would just sort of second the opinion that the take-home message for asthma programs is that it is indeed worthwhile exploring partnerships with weatherization programs and other healthy housing programs. And I think one thing I would like to say is that as you start that process, you're going to identify some immediate challenges. But there are models. I think there's a lot of growing momentum around these kinds of partnerships, and there are existing models where this has been successfully done. There are lessons learned, there are case studies, there are peers to connect with. There are a lot of tools to support you. You'd be part of a group of innovative leaders, but you wouldn't have to dig the road on your own. There are a lot of people who are doing this work and talking about this work, and it'd be great to have more asthma programs be a part of this conversation.
Neil, is there anything you'd like to suggest any asthma program could take from this data that we haven't said yet?
I just want to maybe underscore something that I've learned talking to the Kansas City, Missouri Health Department, and that's that word of mouth is the sort of the best bit of recommendation that you can get. So that building on the successes that people develop in their own communities can really sort of break down some resistance to taking up the what aid is actually available. Right? If you go and people are experts in their own community, and when they see the benefits that that are out there, that strikes me as something that really emphasize in terms of building this sort of successes.
I think that's great, and I hope that it's obvious to our audience today. That's what we're doing with hosting this webinar. We're trying to make sure we spread this story, spread this data, spread this success, and others can use this story and what you're hearing when you go to talk to partners locally. Many of the people on this webinar today in this panel have been part for many years of trying to build the data, build the story, build the proof, connect healthcare with energy efficiency, with housing to address the indoor environment. And we've definitely seen that if you can show this kind of population level impact, 40% improvement, that people stop and take notice. Another thing I'll say to every asthma program, and you've seen it happening on this phone call and in the chat, sometimes we need to take the time to build a common language with a new partner when we may not understand what weatherization is, and weatherization may not understand what environmental interventions for asthma are. Sometimes it takes a little time and talking to recognize we share an overlap here. We share a purpose, and when we can align the language we're using to understand each other, it's worth the time to understand what is weatherization, what is air sealing. This language takes a little building, but if you're an asthma program, I encourage you to try to learn it, and I promise it's not more complicated than any of us can learn. And as somebody who spends time in an indoor environment, we all want to know about these things. I would say we all want to know about air quality, ventilation, and how to keep our houses clean. Everyone in the chat who's asking what kind of education is given to occupants on how to keep their houses clean, I think that varies by program, but there are some standard educational materials that you can see at things like the weatherization website, the National Association of Community Service Programs that Kevin mentioned. And, oh, somebody said take a tour of a weatherization training house. What a cool
Yeah.
idea. Kevin, you can tell folks how they could do that?
Well, it depends on the program, but many of the community action agencies have demonstration, even desktop demonstration, and then many of your state energy partners also might have some of those educational things. And there's all sorts of excellent publications and educational resources. I know I can certainly help anyone, and I know Ann could too. So, and obviously EPA has some just fantastic resources that if you haven't looked, I absolutely recommend you look at, including Asthma Community Networks. And HUD has excellent resources. CDC has excellent resources. A lot of our federal agencies, actually California alone has some. I love all of it. And there's plenty out there. You just have to know what to look for. But there really are excellent resources. As Ann said, a lot of this stuff we've been doing and continue to do. So you're not, if you're new to the field, there's lots of already existing excellent information that you can take advantage of. National Center for Healthy Housing has great resources at their website. It just starts to pop into my head, all these great programs that have wonderful
There are so many
resources.
Right, and NCHH is one of those organizations who we fund to provide communities with technical assistance. So if you are an asthma program or you are in a weatherization program and you're looking to extend your partnerships, I encourage you to reach out to NCHH to receive some potential technical assistance. And if you're interested in securing funding for in-home interventions as an asthma program through Medicaid, Ann's organization, RAMP, is also available to provide technical assistance. Kate, I think we're a little over 3:30. Do we want to try and do the poll quickly? This has been a wonderful discussion, and I just appreciate all the panelists for making the time today, and I appreciate all of you who are here joining this webinar. Really quickly, we greatly appreciate it if you could just take a minute to answer the poll again, and then we'll see how we did in terms of meeting our objectives for today. So Christina, I'll leave it up to you to decide when to close the poll and display the results. All right, so we've moved the needle. When we started the webinar, the top two options totaled 50%, and now they're at 90%. So that's great to hear that folks feel like they are more familiar. You feel like you're more familiar with weatherization as partners for indoor environmental interventions for asthma. Christina, if you could go to the last slide, please. Again, you heard Kevin mentioned, Kate also mentioned asthmacommunitynetwork.org as a resource for you. You can go there to find recorded webinars, including this one once we post it, but we do have a previous webinar series on IEDOH, as well as many additional resources. So I encourage you to join the network, and that will help ensure that you hear about the next webinar we'll host in the series. And that is a webinar where we will be focusing on wildfires, IEDOH risks, importantly, particulate matter and fine particulates from wildfires, and filtration and air cleaning interventions for asthma. So I think, again, the chat, we heard a lot of talk about these technology. So please do join us for that third webinar in the second series for solving for the indoor environmental determinants of health. And with that, I'll say goodbye and thank you.